healthcare, there is often too much information and not enough time. Here at the Melanin Initiative, we avoid TMI. By breaking things down into language you can understand, we create a safe space for you to ask your questions and share a nursing perspective without taking up too much of your time. Today, we're going to be talking about amputation prevention. What are amputations? How common they are, risk factors and diseases associated with them, treatment options, who will be on your team if you need to have one or have it managed, as well as prevention. If you're new here, welcome to the Melanin Initiative. I'm Dr. Kimberly Madison, a doctorally prepared nurse practitioner, and I co-host this podcast with Alicia and Geraldine, who send their love in their absence. We are a health literacy podcast, offering our nursing perspective. When we say health literacy, we're talking about the ability to obtain information, to understand that information, and to use that information to manage your health and advocate for others. By watching on YouTube or listening on your favorite podcast app, we hope you feel empowered to ask questions, educated on how to manage your health, and confident to navigate the healthcare system. If you haven't already, please subscribe so you can be notified when we release a new episode. Thumbs up the video and leave a comment or two. It really helps support the show, and it lets YouTube know that this information is valuable and it gets the message to those who really need to hear it. As a reminder, this show is for educational purposes only. The opinions expressed here are our opinions alone. They are not a representation of any of our affiliations. If you are experiencing a medical emergency, you can call 911. If you think you might be having a mental health emergency, you can call 988. So excited to welcome Dr. Yvette Conyers. She is a doctorally prepared nurse practitioner, another DNP. We've already rolled out in season 2 our new series on becoming Doctor of Nursing Practice with Demetrius Kirk. So you can go back there and find out what that education and training looks like. Today, we're going to learn about amputation prevention. And I'm super excited about this. I think this is a really important topic for our community. And I hope that it makes a difference in somebody's life. So welcome to the Melanin Initiative, Dr. Conyers.
Thank you so much, Dr. Madison, for having me. I'm very excited to talk to y'all tonight.
Yeah, this is really special. Really honored that you would take some time out of your busy schedule to share your knowledge and expertise with our community. I know this is really going to, hopefully, really the hope is that it saves some lives and saves some limbs.
Yeah. I think that's the goal, provide the education. And then, as you mentioned, I love the health literacy part. It's not just about the information that's being provided, but how can people take that information and apply it to their situation for better outcomes?
Wonderful. So before we jump in, if you could just give us a little background on who you are, where you're from, and what you do when you're not on podcast.
Yeah, so as great introduction. So as Dr. Madison mentioned, I'm Yvette Conyers. I'm a doctorally prepared nurse. I've been a registered nurse for over 20 years, a family nurse practitioner for over 10, and a DNP for almost 6 now. It'll be 6 this May. I am currently residing in Baltimore, Maryland. I'm at the University of Maryland as an associate dean for equity, diversity, and inclusion, and assistant professor. And then in my F&P role, it's really a combination of my RN role and F&P role, and I work as a foot care nurse. And we'll talk a little bit more about that as we delve into today's topic. I'm born and raised in Rochester, New York. I have one son, and most of my family's up there as well, but everyone's thriving and doing well.
Oh, that's so good. Another New Yorker. My parents are big fans of the show. They'll be leaving comments. My mom's from New York. She thinks only the best things happen in New York. So I know she's already excited.
Hey, Mom.
Yeah, we have a lot to cover. So let's just jump into it. How do you describe amputations to your patients?
Yeah, so I tell them it's pretty much the removal of a limb, right? Many times people think amputations, they think of the feet or they think of toes, but it can be any limb. It can be a finger, it can be a hand, it can be an arm, and they happen for a variety of reasons. Upper extremities, mainly trauma related injuries. I think motor vehicle accidents or explosions, or you think your folks who have served in the military, right? Related to trauma, but then lower extremity, especially those who have diabetes and living with that condition, they can also and are high risk for developing amputations related to various disease processes that we can go over as well. So it's usually the loss of a limb, medical illness, surgery related, or trauma.
What inspired you to get into this specialty?
Yeah, so that's a great question. And this started probably my journey started about 5 years ago. I was the previous president of the Rochester Black Nurses Association, a chapter of the National Black Nurses Association. And we had a wound care nurse practitioner come over to talk to us at one of our meetings about increasing diversity in wound care. And one of my colleagues, Dr. Celia McIntosh, asked the question about foot care and representation. And the response to me blew my mind. And the response that was that in the Northeast region, there were no certified foot care nurses, or CFCNs abbreviated, under the umbrella of the wound ostomy continence nurse, or WOCN nursing umbrella. And that really shocked me and it really bothered me. And that is actually what started my journey to becoming a certified foot care nurse and blending my NP role with the CFCN and how I can make a difference in amputations, specifically on prevention and education.
Wow. Are you certified as well?
I am in process. So I finished up my didactic. I'm getting ready to start my clinicals in April, and then I'll be sitting for my CWCN, which is Certified Wound Care Nurse AP, which is advanced practice. So my goal is to combine the blend of wound care and foot care nursing, looking at treating acute things. But again, I want my focus to really be on education and prevention and looking at the cost savings.
Yeah, I love that you shared those other certificates, because one thing I'm trying to do through this podcast and through my legacy is not only promote and elevate nursing and what it means to be a nurse, but the many options in healthcare, right? Because everyone's told be a nurse or be a doctor, but we know there is a team of people in this field. And I think the next generation should know about, other people even changing careers should know about
Yeah.
all these other options and the different ways that you can advance your education.
For sure. There's so many certifications out there. It's about finding your niche. For me, wound care and things like that, it's an art to it. You know, you see the progress, you see the healing, you're making that selection in conjunction with the patient on what could be best for them. And when the outcome is that healed wound or their ability to walk again, or, you know, some of their complaints that they had are gone, it feels good for both.
Yeah, and for our audience who might not be familiar with what is it to be a nurse, you know, a lot of our focus is on disease prevention and health promotion. That's what I feel like we are the experts in that area, and so I love that you really gave a lot of attention to that in your response.
Yeah, thank you. I think it's important, you know, and especially again, going back to health literate information that they can understand and apply. We as a community, we as a nation are focused on tertiary care, acute care, hospital care, rehab. And I think as much as I can, driving the efforts back to primary prevention and secondary.
I love it. We talk about primary care here a lot, and I think this falls right into that same basket. And I know as a nurse, we spend a lot of time talking to patients about the importance of their skin, and it is kind of a challenge because if they've never had a,
Mhm.
and so when they do develop a problem, they don't know how common it is. So let's talk about kind of the prevalence and incidence rates of amputations.
Yeah. So I would say lower extremity arterial disease, or lead, is usually what drives folks to then have to succumb to an amputation. It's a chronic disease, it's a progressive disease. There are different risk factors for lead, which is like smoking, advanced age, diabetes, someone who has like hyper cholesterol or high cholesterol, high blood pressure, family history, and then sedentary lifestyle. So if folks can just pause and think about if any of those they may have, these can be risk factors. Of course, you know, when you look at more statistics, it does affect those age 40 and older, but more commonly those over the age of 60. And then even more so if someone has diabetes in conjunction with lower extremity arterial disease, which is a decrease in the blood flow, you know, and back up to the heart, that actually increases the prevalence to about 30% for someone who has both lower extremity arterial disease and diabetes. With a lot of these diseases, we do understand how racism plays a role. And so you will see things like Black as a risk factor. It's not necessarily that I'm Black that I have an increased risk factor. It's the ism part that goes with it, and the social determinants and the systemic issues that have been embedded in healthcare systems, that when folks say X, Y, and Z race is at increased risk, it's not, again, because I'm Black, it's about the racism component to it. So understanding that, as well as our non-Hispanic white are also at increased risk. I think that also may be due to health, to literacy, and ability to understand information in their own native language, especially if they are Spanish speaking.
Wonderful point. And I love that you brought up smoking, because so much of the emphasis is always on like cancer, right? And we know that even people without cancer get lung cancer, right? Or without who don't smoke
Yeah.
also get lung cancer. But I think it comes as a
Hmm.
surprise to a lot of patients. And a lot of times they'll say, "Oh, I quit smoking 20, 30 years ago." And
Yeah.
and it's really heartbreaking, because they did do a good thing. But the damage was
Yeah,
just, you
damages
know.
are done. Yeah, and smoking, it decreases the arteries to be full of that blood, to be full of that oxygen. And so you got all these arteries, if you think about in your lower extremities, that's the last to get the perfusion of blood, right? And so all these other things can contribute to your toes and your feet not getting the circulation that they need because most of your blood is trying to get to your heart and get to your other larger organs. And so if we can modify or decrease the risk factors as much as possible, that would help. It's important to understand about 150,000 people undergo an amputation each year. And half of those, right, are related to those who have diabetes. So we're just talking about lower extremity amputations. You can have a BKA, which is a below the knee, a AKA, which is above the knee, or you can have like foot amputations, different parts of your foot, more commonly TMA, which is transmetatarsal amputation.
Oh, excellent. I love that you brought up social determinants. Do you mind just giving us a quick little blurb on what you're referring to?
Yeah, so social determinants of health account for about 60 to 80% of healthcare outcomes. So these are how we would define it is where people live, work, play, age, right? All those things that impact them outside of true healthcare. So someone's ability to access fresh foods, the security of the housing that someone's in, including lead exposure or droplets that can then increase respiratory issues, someone's walking ability and feeling safe in their neighborhood so that when you say, I want you to do a walking program and I want you to walk outside, well, doc, I'm not sure if you really want me to do that because X, Y, and Z. A lot of other things go into it too, as well as some policy implications. But it's about all the things that can affect someone's health outside of that healthcare piece, which is a lot.
Yeah, excellent. I think the statistic is what we do in healthcare only accounts for 20% of their outcome, and 80% is related to all those other determinants or factors that you mentioned.
It really makes you go, right? And again, it really makes you to think about if we're working in acute care, and there's nothing wrong with whoever wants to work in what situation, but you're putting all your money and folks are putting money and energy into that 20% versus if we can look at policies, if we can look at education, if we can look at how we are truly supporting that other 80% for people to have, increase longevity of their life, especially in this amputation world, understanding that globally, actually, every 30 seconds, a leg is amputated due to diabetes.
Mm. Yeah, and I
Every
also
30
love
seconds.
that's a lot. I love that you mentioned too that what I like to say is a diagnosis does not have to be a destination, because so often we think, especially in our community, if grandma had it, if my uncle had it, everyone in my family had it. So it was,
Yeah.
um, only inevitable that I would get it. And now that I've got it, there's really nothing that I could do about it. So I'm not really going to make these changes you're trying to tell me about because I just feel like, this is it. And that can also be associated with depression and anxiety too, if I feel like I don't have any options.
Yeah, definitely can. It's not a life sentence for sure. Although, having a family history is one risk factor, it's not an end stop, right? It doesn't mean that you're right. There's a death sentence to it.
Yeah, and so that family risk, it could be genetics for sure, but sometimes it's behavior that gets passed down, right? And the reason
Yeah.
mom had it and grandma had it and your uncle had it was because they all lived the same lifestyle. They all had made the same decisions when it came to diet, exercise, movement, whether they were going to smoke, participate in drugs or alcohol, things
Yeah.
of that nature.
Yeah, definitely a lot of it has to do with the behavior choices that a lot of us in other chronic diseases can happen, but it's also important to realize a lot of it is unfortunately things like place-based. So where you live, right? Your zip code matters. And we've heard that probably in other situations before. So there's been a lot of research in this amputation world and like peripheral arterial disease or lower extremity arterial disease about your zip code matters. And if you look at these maps and these heat maps, it's the overlay of them is that where you have pockets more of Black and brown people, you actually have increased rates of amputations associated with these areas. right? So zip code does matter. And those are the things that, again, make us go, why is it that in these certain areas of these major metropolitan areas, if it's an increase in certain ethnic groups, we also see an increase in amputations, as well as Medicaid, right? Insurance is also, if you look at another heat map, those who have like Medicaid insurance, there's also overlap in those areas. So a lot of different systemic and structural changes that we need to look at in addition to the individual behavior ones.
Thank you so much. So let's, any other dissociated diseases you want to bring attention to or add on why those diseases are
Yeah,
so?
yeah, in addition to, I mentioned LEAD, LEAD, you can also have an increased risk of amputations related to LEND, which is lower extremity neuropathic disease, which is related usually to diabetes. You can also get neuropathy, which is loss of sensation of nerve endings, usually in the extremities because of like chemotherapy for someone who's undergone some treatment. So LEAD, LEND, and then you also have LEVD, which is lower extremity vascular disease, which doesn't account for as many amputations, but again, arteriovascular, all about the circulation in our body, what's going down, what's going back up, and how our body is able to do so. And then if someone does have diabetes, the neuropathic disease that is associated with that.
Oh, thank you. That was a beautiful explanation. So yeah, that, a lot of times when patients, the first thing they'll say is, oh, I maybe have some numbness or some tingling. And I find the challenge with not only explaining the disease itself is the pain management and how challenging that could be, and kind of realistic goal setting with patients around that.
And I agree with that. And, everyone experiences pain differently. The pain is what the patient says and how they experience. For me, again, going back to that prevention, if we can, nerve endings that die won't come back, but we can prevent further ones from deteriorating and getting worse. So it's about doing exams such as a monofilament exam, where I'm checking to see on different areas of the foot if someone can feel the sensation. I'm doing those ahead of time. I'm trying to be proactive. And there's other tests that be done proactively to try to mitigate the complications of neuropathy and also the depression that can come with that because of it's a pain. It's pain.
Yeah, very, very debilitating, actually. And then, and so the reason that, that neuropathy is such a risk factor, right? Because they can't feel that there's a small cut, so they don't take care of it. That small cut
Yeah,
becomes a big wound. That big wound then puts them at risk because that
exactly.
circulation is impaired because they don't have the oxygen and nutrients to get to those tiny little parts of the feet that are so far
Yeah.
away from the
Heal the
heart.
wound. Yes, yes. So I remember a long, long time ago, I was working as a nurse in home care and I was seeing an individual who had a wound and he had his first metatarsal and second metatarsal, so his big toe and the second toe amputated. But what happened is he had diabetes, not controlled. His A1C, right, was not controlled, which is that every 6-month number that your doctor may do to determine how well controlled your diabetes are over a span of time. But he wound up stepping on something sharp and never felt it, right? Never felt it in his foot. A month goes by, 2 months goes by, and then, notices increased pain and drainage and odor. And now it's infected into the bone, which is osteomyelitis. But now they have to go in and do the treatment for it and also the amputation, and a lot of stories are like that. Some not so much, but many are.
And so that's why we tell our diabetic or patients who have diabetes to always check their feet for that reason, because if you can't feel it, then you're not going to know something's there. And when you get to that point where you have diabetes or neuropathy or something and you just can't bend and touch your toes anymore, it kind of is like the first area that gets neglected, and it's like, oh, they're dry, they're always dry, but no big
Yeah.
deal. And they're rubbing my shoes, no big deal.
Yeah.
And you don't realize like it's building up, sometimes quickly,
Mhm.
sometimes for a long period. But that's one of the reasons we want you to check your feet so you can find that small crack or
Yeah.
notice that it's so dry that you need to do something so it doesn't open up.
Yeah. And if someone has a caregiver in the home, I recommend if they can't see the bottom of the feet, they can use a mirror, right? Just get a
Mhm.
handheld mirror, look at the bottom of the feet, or ask a caregiver to look at it. Or, obviously there are specialists, but we're talking about daily foot inspection. And so if you don't have a caregiver, a mirror can be your next best option if you're unable to lift your feet up.
Excellent. So you were talking about amputations, but are there things you're doing prior to the amputations, like medical management, before we get to that limb salvage?
Yeah, so even before amputation, they're going to do something called an ABI. So if there's indication that someone has some perfusion issues with the arterial system, they're going to do an ABI, which is an ankle brachial index. It's a diagnostic test that looks at it. It takes the systolic pressure of the ankle. It's a mathematical equation. It's take the systolic pressure of the ankle and then of the arm. It's like a blood pressure cuff that you would put on your arm, but there's one that goes of your ankle. You take it, right, left comparison, arm, take it, right, left comparison. And then there is sort of, if it's between 0.8 and, 1, you're okay, right? If it's greater than like 1.3, you got some calcification of the vessels going on. If it's less than 0.8, that means that you're not really a candidate for compression therapy, which would be recommended for people who have edema or swelling in their lower extremities. So an ABI would likely be done, again, as well as some of the other testing I talked about, the monofilament, as well as some sensation test, proception test as well, to see if you can feel where I am. And then you'll get referred. So if your ABI isn't that great, then you'll go see a vascular surgeon, and that will likely be the next step to determine if you need to have stents or some type of surgery placed to increase the perfusion to your lower extremities, or, if other options need to be done. If you do have a diabetic ulcer and that needs some surgical treatment, then there's options for that. If it's not surgery necessary, then wound care. But you have many different disciplines. Interprofessional collaboration is important in this space. Physical therapy or OT may get involved if someone's had an amputation, specifically related to phantom limb pain, feeling like that limb is still there and it's not. A psychiatrist may be involved because of the emotional trauma, infectious disease, of course, your primary care, and the list can go on. So it's comprehensive.
Thank you. Thank you so much. Real quick on that monofilament, are you using a tool to do that?
Yeah, so it's a tool. It's Simmons. I forgot the full name. It's a German tool, Simmons something. It's 5.07 is sort of the gram or the weight. And you apply light print, it should take a bend, the small tool. I would say it looks like I don't have it with me, it's downstairs, but it's a small, flat, flexible tool. And if I apply pressure, it should bend. And with the person's eyes closed, in certain areas of their foot, they should say, I feel it. If they're not feeling it in certain areas, that area can be full of or have neuropathy associated with it, which is then it's really time for us to look at prevention, specifically of the ulcers that you mentioned, so that we don't have any further damage that can lead to the amputations.
So when does someone get sent to you? At what point in their disease process?
Yeah, so I'm early on. So my goal is if someone has diabetes, mainly diabetes, but other foot care issues. So realizing that everything's connected to your feet. You may be having back pain, hip pain because of your gait in the way that you're walking, right? Or compensating. And so those may be reasons to come and see me to start. And then I would do like a gait assessment, a shoe assessment, ask about your medical history, your medications, things that I know can impact your vascular and arterial circulation. But I'm usually earlier on, and then I'm referring, if need be, to podiatry. I didn't mention them earlier, but to podiatry, who are surgeons, right? As a nurse and as a nurse practitioner, I'm not a surgeon. I'm not a podiatrist, and I don't claim to be. Sorry, it's raining. And I love what I do in the nursing aspect because of the education I bring with it and the holistic measure. If I'm referring to podiatry for something more complex, I'm going to let them do those things because, again, they're the surgeon. But I'm the one you would see earlier on when it's like, hey, I'm starting to have trouble bending over, reaching my toes. I'm starting to begin to notice a weird sensation in my feet. I'm noticing my shoes are going inward, inversion, those type of things.
Oh, beautiful. And so are they getting referred to you by primary?
Yep. So primary, but also if they're going to see If they're going to maybe even a shoe store, I work with all folks like Good Feet shoe store, right? If they come in and they're getting measurements for their arch support and things like that, and someone at the store thinks that I can be useful to them on the physical aspect, they'll send them my information as well. A lot of it's word of mouth in advertising, but also just being out in the community, real boots on the ground. Those experiencing homelessness is another group of folks. And then finding people where they are, library, churches, etc. And you realize when you take off people's shoes and socks, it's a lot there that that's the last that they sort of think about. As you mentioned, people are not removing their socks daily, not washing their feet daily, and you see it. Yeah.
And you mentioned compressions. Can you just explain what that is?
Yeah, so compressions is there's various forms of compression therapy, but it's usually for someone who has excess fluid or swelling or edema in the lower extremities, so from the knees down. So someone may just need some light stockings to help with compressions. I know nurses use stockings a lot to help with getting that blood flow back up to the heart as they're walking a lot of the time. But if someone has increased swelling and having a hard time getting that fluid back up, then they may need more of a tighter compression therapy, in which an ABI, as I mentioned earlier, that arterial brachial index would be done as well to ensure that someone can tolerate the compression therapy. The compression determination of what product will be used would be, done in conjunction with the wound care provider, as well as a vascular provider, as well as a certified foot care nurse as well. And then with each of those comes how often it's left on, the do's and the don'ts, those type of things. Again, a lot of education.
Excellent. And you kind of have started talking about it. Anything else you want to say about prevention?
Yeah, sort of just reiterating the diabetes. If someone does have diabetes, which is again 50% of amputations are related to diabetes, and of that 50%, 85% are due to a diabetic foot ulcer. Keeping that A1C under control with you and your PCP discuss is going to be very beneficial. If you need to see a dietitian, great. Also, professional foot care in prevention. So it's great if you want to go to the nail salon and get your toes painted, but at the end of the day, you need a professional person to be able to provide the education components to and provide some recommendations as well. So encourage professional foot care or professional nail care by someone like a foot care specialist, your podiatrist, a foot care nurse. Just being mindful of if you see any changes, to speak up, let your primary doctor know. They should, if able, be removing your socks and checking your feet. As someone who has diabetes, quite often you're due for a yearly annual diabetes exam, but there's also some other things that should be done, on a more regular basis, like every 3 months or every 6 months. So advocate for yourselves, try to speak up when you're at your appointments, but certified foot care nurse as well.
Thank you for adding that piece on. I really appreciate that you took time to bring that up. Anything else you want to say? Oh, you talked about the podiatrist. I just wanted to give a shout out to the DC foot doctor. Do you know him?
No, I do not.
Yeah, and I wish I his real name, but that's his YouTube channel. I love
Okay.
his content. I know
Okay.
it's all about feet, nails, corns, bunions, but
Yeah.
people have agreed to let them film that he shows it just from like the knees down. He has excellent bedside manner. He never makes people feel bad for what has happened.
Mm.
He provides the education. You hear your patients are concerned. You hear that they want to do better, that they're interested in improving their health. I just love it. And I think it's a great name, DC Foot Doctor. That's so easy. He
Okay.
has
I'm gonna have to
um,
check into them.
yeah, please do. He has a Amazon store, and he has put some recommendations in there that I have used for my patients and myself and my mom. So it's like
Mhm.
I can always say, yeah, the podiatrist recommends this.
Yes.
Yeah,
Yeah,
check him
that's
out.
great. No, but what I'm hearing you saying is that he's building rapport and trust, right? And that is the foundation of therapeutic relationship. In order for we may use the term non-compliant, right? I don't like to use that term. It's about building relationships and trust and figuring out people's why, right? And it
Yeah.
sounds like just from that little snippet that that's what he's taking time to do in that non-judgmental way, and truly trying to understand the patient from where they're coming from and working together on how we can, make some changes.
And the outcome, I mean, he makes people's feet look great, as great as they
Yeah.
can be. So it's really, really educational. I think it's like over 500,000 followers. You can tell
Okay.
that the thirst for knowledge is definitely
Yeah.
there,
Mm-hmm.
and it's good to
Mm-hmm.
see that.
Yeah.
Well, thank you. You
Awesome.
want any final thoughts with the audience on amputation prevention?
I would say do your research. Obviously people are going to go on, different sites to try to fit out, but then bring it back and have conversations with your nurse at your doctor's office, or, the podiatrist if you're already seeing them. But try to get ahead of it as much as possible. If you're noticing some drainage, if you're noticing just something isn't right, don't wait too long. Go ahead and speak up. If you're noticing that some sensation just isn't right and you're not feeling it in certain areas, try to advocate for yourselves and get in to see someone sooner than later.
Thank you so much. You provided a wealth of information. You
You're
introduced a
welcome.
lot of new vocabulary words to our audience, and we just really appreciate you. I honestly enjoy being able to put nurses and nurse practitioners in this spotlight so that you can demonstrate your excellence and your level of knowledge and show what it really means to be a nurse.
Yeah, yeah, I love it here. And thanks to my colleagues 6 years ago, I would have never thought about this as an opportunity, but I'm looking forward to this journey and continuing it.
Thank you. And I love that you told us about the need to improve diversity in this specialty. And so we'll have to talk more about that in the future.
Yeah,
Remember, everyone, you can email us your questions or show ideas to tmi.melanin@gmail.com. If you haven't already, please subscribe to our YouTube channel, follow us on every social media platform, say hello in the comments when you get there. Please share the show with your friends, rate us on the Apple and Spotify podcasts, leave a comment. It really helps support the show and gets the message to those who need to hear it. You can find all our social media links and any resources that we brought up today will be in the description box. Remember, we release a new show weekly on TMI Tuesdays at 10 a.m. on YouTube, LinkedIn, and all your favorite podcast apps. Follow, like, and share content. We thank you, Dr. Conyers, so much for your time, and we thank you all for watching. We'll see you next time.